Why don't we go ahead and get back started? Can we go ahead and get started again? Well, we ended up ending the last session a little early. I apologize, I was off. But about a fourth of you had gotten up. So I felt like, well, I rushed sort of the end, so I want to take a few more minutes and make sure there are not questions, comments, or other aspects. I mean, one of the people caught me during the break and said, you know, the problem they were encountering was politics and the people higher up. And how do you handle that? Because in the past, when people have been outspoken or advocates, they've been pursued negatively. I've not actually gone into tactics, but I mainly talked about is principles. So let's talk a little bit about tactics. I am not saying that you should not be politically correct. Okay? I am not saying that when you're an advocate that you're trying to attack or disagree with people. What I'm trying to do is trying to say the messages need to get out there in ways that are effective. And your context may vary. For example, if you're new into an agency and your leadership is not used to getting direct input, then you need to find tactics that are appropriate. Again, with most relationships, you need to develop trust, credibility, and ultimately value for them to have a relationship with you. And so if they're in higher up positions, you need to find ways that you are perceived to have trust, credibility, and added value. One of the strategies I mentioned to you was the need for quick successes. You need to find some areas where you can pursue results, data, or other thing on an issue that is valued and helpful in a quick stud to grow with even if it's a small issue, but it shows the quality and capability of what you're doing. The other thing that I have a long history of doing is I don't try to attack people publicly or in meetings. My preference when people are stepping out of line and even leadership is saying things that are not quite right, I tend to go back to people directly and on their own because I want to show that I respect them and that they can trust me and know that I'm here for their better good. So sometimes what I will do is I will go and communicate afterwards where you said the following things. I just wanted to follow up with you. I'm concerned about this, and this, because this is the data for this, this, and this. And I just wanted to make sure that you had the right information. Let me know if you have any questions. So again, if people feel like you're there to support them and back them up, ultimately, when they trust you and they give credibility, they're not going to mind you disagreeing as long as you disagree in a context that's acceptable to them that they can receive it. Does that make sense? Because no one likes to be wrong. I mean, I commonly do that with vital records in my relationship. Frequently, they won't necessarily ask me to review a report in advance. And so what I do is I look over the reports, and when I find errors, and I usually always can find some errors, I actually point them out and send them to the person who's responsible to let them know what the errors are. And you know what they eventually do? They actually start sending me the reports in advance so that I might review over them and give them comments and suggestions. And I don't do it in a public forum. For example, in South Carolina, they were still, when I got there, referring many years back to people as white and non-white. And I'm going, you know, that's really not probably a good way to do it. You probably should call it at least white, black, and other, because that group is predominantly black, and it makes people feel not owned and valued. And, oh, Bill, we can't do that, and this is the way we've always done it, Bill, and on and on and on. And they finally needed to do some minority health reports from the commissioner's office, and guess what? They started to use black and other. So, I mean, seeds were planted, but they knew that I wasn't going to go out, attack them. I wasn't going to go to the commissioner and tell them how bad this was. The key gets to be is we're all in there for the common good, and I give people the opportunity for change. So do think through that. Yes, ma'am. They're always worried about the messenger. So the first piece gets to be is, if you are a messenger, that means ideally you're not in the right place. Because what you should be is a member of the team. Okay? Think about those as different roles. If you're a member of a team providing information or you're a messenger, you're going to be perceived differently. So one of the things you want to do is you want to start trying to develop a relationship so that you're not always perceived just as this independent person who's come give them bad news, but that you are there in support of them. And that what you want to do to be there for them is ensure that they can be the best that they can be. And that my interest is to assure that you can be the best that you can be. And if I have bad news, it's like with a Healthy Start, I started to leak it, so I'd be tempted to invite them over. You know, I've got some of these initial runs, and I'm looking at some of this data, and this is what I'm seeing. What do you think's going on? Am I missing something? What else should we be looking at? Is there a better way to do that? Do you think we have some data quality issues here so that I start trying to, in other words, instead of waiting to the end, and here's the bad message, when I went into that evaluation, I would be trying to meet with them regularly. So as we develop tables, as we start getting results, they are part of your report. So by the time you get to the end, you're not the messenger of, here's how poorly you're doing. You know you've been working collaboratively on the report to see how you're doing. And remember, you know, and you can even tell people, I say, you know, if you've not looked at this before, I even tell people now, if you've not looked at this before, you need to be prepared to be surprised. Because things you haven't looked at, guess what? You tend not to be doing nearly as well as you think you are if you've not looked at it. Two, if you haven't looked at it, that data quality may also be poor. So sometimes we need to start working on reporting the data. So not only can we improve the quality of our performance, but we can improve the quality of the data that we get because it now becomes important. Does that make?
Yes, it does. I'm kind of in a unique situation that our EPIs are extracted from our programs. We're in a completely separate work unit.
There are dynamics, though, of people who are in your exact situation who still can change that pendulum. Because if that project gets assigned to you, you can still go meet with them and have a project team. And remember how I had that triangle and who needs to be involved? Even when as soon as that project gets assigned to you, it doesn't mean you have to just go off and run the numbers. You can go meet with them. You can talk about what your plans are. You can lay out the tables that you're thinking about and the measures that you're thinking about. You can get them to buy into it. The advantage of that is, one, you're making sure that the numbers they're going to get are the numbers they want. And then two, they're now vested in seeing what the results are. And they know that you're working with them. You're now just that group over there who's going to give me bad results. Does that make?
Yeah, it does. Thank you.
This just sounds to me very much like what you would do for community-based participatory research. It's like the same process of involving people early and often in designing the project.
It's not just community-based, it's called people. Guys, it's relationships in people. And it's about trying to get common results. And the only way to get common results is if we do it together in common. And people need to know what your intent is and where you are. And when you're assigned that project to go work with that program, your intent is to work with that program to make that program better off. Better off may mean they aren't doing very well. But better off may mean that you're there to try and give them the data that they need to be better off. Does that? I mean, there's this tendency in academia that you want to say independent so we can have this valid, separate. But you're not there trying to determine a randomized trial or an evidence-based program. You're there trying to give information back to the program. And what you also want to be doing is you actually want to be teaching them that they could be doing what you're doing. I'll say it again. You want to be teaching them because some of what you're doing they could do or they should be expecting on a regular basis. And so you're trying to, I call, build that team capacity from your role.
We had a similar issue with a program that I work on, and we found a really helpful resource in Gianni's data fluency work from GIS Analytics. And what they're finding in large corporations is that there are the silos, but then also the culture determines how the data are being used or not used within an organization. And we actually were able to bring this back as a topic of conversation to our larger stakeholder group and develop what we coined as information empowerment, because we've done empowerment implementation.
It's all about empowerment. That's a very, very much so.
When we talk about, I like what you said about values, because when we talk about data now, we talk about it from a values perspective.
Oh, the other thing goes back to the point I mentioned that Josh Miller says, if you haven't told them 20 times, they haven't heard you. So meeting with the program, you're going over it again and again and again. And initially, they're not going to want to do the data, but eventually you want to get them to the point that they can talk about their own data. Because if they need to improve the quality of their program, they need to be able to talk about their own data. They may not be able to generate it, but they've got to be able to communicate it. And they're not going to do that getting one report.
Just a thought. I really appreciate you talking about the importance of, I mean, you're almost saying that we should be embedding ourselves in all the service, all the units that we provide service to, which isn't typically how it's structured. And sometimes there's resistance, but I really appreciate hearing the importance of that.
Well, remember that structures are not there to, in my opinion, to be barriers. Structures are there to provide support for the work that you do. But no, you'll know, when I was in Florida, they would consider me as much a part of their team over in Vital Records as in the own unit that I was at. I basically even though everyone knew that one of my roles was being the director of the office of MCH, what do we call it? MCH, wasn't program evaluation, I couldn't use those words. We had to come up with words we didn't sound like somebody else's unit. Otherwise, they were going to absorb us and put us in the same unit just because we had similar names. I think we call it MCH Practice and Analysis Group. But I also played the role of state MCH epidemiologist. So I would go beyond my own organization and work within not only the divisions in the area that I was at, but I work in other divisions, and I would work with counties and others. Now, the key gets to be is my organization needs to get credit for that. They also need to value that. But I try to demonstrate it's about the overall mission. It's not just about your organization only. Now, I don't mean to say I don't respect my organization. I don't mean to say I don't make my organization look good. I'm just saying I don't need to consider my organization as boundaries. You could say, well, you can only communicate through that program through the higher-ups. Well, then, that's with all my official communications will go through the chain of command. However, if I'm working on a project, that's not an official communication. We're forming a team to work on a project, so I can work on that project without that being an official communication. Does that make? Now there are leadership who want to micromanage and constrain you And those are other tactics that you'll need to work through. But I'm trying to talk about what you can do. And again, some of these things I'm telling you may not be able to do immediately. Some of these things you need to do on an incremental basis. I mean, it's not like all of a sudden you can just offer yourself to the world. But you can do it in small steps at a time. And if you show that these other approaches work once, then they may become more accepted by others. Does that make sense? Now, you might say, well, I'm just too busy. I just got to generate the report and get it done. But then is it about just getting it done, or is it about quality and what you're trying to do? And sometimes, frankly, guys, you just got to get it done. I mean, I am a pragmatist. But again, there's what I got to do in the short run, and there's what I got to do in the long run. What happens to most people is they stop looking at the short run. It's like needs assessment in the integrated process. I know what that planning process needs to look like. So there's what I got to do now, but I know where I want to get. And I talk about having my plans in my back pocket, so I just pull them out when the opportunity arises, so I can expand it or do it the right way as opportunities let me. Does that make sense? So I don't think you can do all these things magically at once. It's not like all of a sudden you can get all your data sets linked and shared across the agency. It's going to take an incremental step, but you have the vision of where you want to get, and you try to build the opportunities that lead you in that direction. And I've also mentioned if the opportunity is not there, guess what? I got other work to do, and I'll just let that sit. Other questions? Yes, ma'am. That's a good question, and that's an incremental question. Usually to me, again, it goes back to I start with what they are trying to do and how data can help them. And the more I can show them the data can help them lead their decision-making process, the more data they want. And they'll just keep on what they want, and then they'll start seeing the bigger picture. Now, again, I've also told you there's some people who just never get it. Our child health program, I could just never get it. And then all of a sudden, they had a major thing come down at the state level where they had to divide up the state into 2 different contracts. And they had to decide which counties were in which states. So I went them through a database process to do that, which came close to what it is that they used. But all of a sudden, they started to decide that data was helpful. Did they use data on the questions that I really wanted them to? No. And everybody's learning curve is on a different perspective. But that's what I try to do. I try to seek out their opportunity. But again, with oral health, it didn't change until our oral health director retired. He only wanted data that he could generate the way he wanted it, and he knew exactly what he wanted, and that's what he did. Other questions, comments? Our next topic is going to be on quality improvement. And here I am. I'm a state MCH epidemiologist, and now, 5 years later, I'm the director of the Florida Perinatal Quality Collaborative, which is strange. So how did we get there? Well, I mentioned the infant mortality, that our big problem in infant mortality was our birth weight-specific mortality rate wasn't improving. And our rates were higher than other places. So one of the first things that came out in our infant mortality needs assessment was the need to improve quality. And so we started to try and work with different groups through our pregnancy-associated mortality review and through other areas to work on quality. And then we then started to look at cesarean delivery and our high rates and the impact cesarean was having on our poor outcomes. And we started engaging with our obstetricians on that topic and trying to get them to listen and accept some of the data because, well, this is just vital records. It's not completely accurate. And so we had to go through all those things of showing studies how it was accurate and it was capturing pieces. And then we got invited by the March of Dimes to the Big Five. They figured out if they could get the Big Five states together, that was 40% of the births of the country, that if they could get us to work on preterm issues of what's currently evidence-based, they could have a huge impact on the nation just by sharing. And one of the biggest issues that came out was quality improvement. And so we went through this visioning process. This is why I talk about developing a vision is helpful. So not only did it go through the vision processing nationally with the 5 states, each state had its own team. So we formed a team in Florida. It included obstetricians, neonatologists, the Hospital Association, our Medicaid agency, and others. And we went through this visioning process. And as we started to see what California was doing and Ohio was doing and North Carolina was doing, it's like, we need to be doing this quality improvement stuff here in Florida. So we got together in 2010 and had a statewide meeting, probably the largest perinatal meeting up to that point in time in Florida. We had about 118 people. And we brought someone in and talked about what we could do with a perinatal quality collaborative in the state and asked them, what do you think? Is this something they should do? And the uniform response was, of course. And why did it take you this long to decide we needed to do this? Literally. That was the response. And our visioning took place with all the key stakeholders. So we used that 1 year later. We had formed the Florida Perinatal Quality Collaborative. It went into the Child Center. We started our first initiatives. Then I got invited to the university. I've been working on it from the health department side, and now I'm in the university. I'm a chair of a department. I'm director of the Child Center where the FPQC is sitting. And so I now switched places and started to be engaged. But we're very different. In Florida, we always say we're different because every other state collaborative in the country is run by a maternal fetal medicine specialist or a neonatologist. Well, ours was begun by a former neonatologist who now is an administrator at the university as an assistant vice president who's not doing any neonatal care at all, and then an epidemiologist and a pediatrician. The reason being was because we didn't have anybody else who would lead it. Florida had no leadership in maternal fetal medicine or neonatology who was ready to take on a population-based focus of quality improvement. And so we knew it needed to happen, and Dr. Curran and I are those sort of people. Well, if we need to do it, we just need to step up and do it. And so we're now, and Dr. Curran stepped down, so I'm now directing the Florida Perinatal Quality Collaborative. And you all may have seen that picture that I showed you. Let's see if I can put that up here real quick. I'm going to boast, but I'm going to use it as an example. That was us receiving the Sapphire Award as the Florida Perinatal Quality Collaborative this past April. The Sapphire Award is offered by our Blue Foundation that gives state recognition to organizations that demonstrate improvement in health outcomes through community health services. And not only, they've been giving this award out now for 14 years. And their award recognizes anyone across the state. And we were recognized as the top organization by them for this year. And with that comes a $50,000 donation. So we're not just talking about some recognition, but we're talking about real support. And we value this because they cover everything, not just perinatal quality issues. They cover pregnancy, they cover aging, they cover homeless. So this was really nice because here we are. We just started in 2011, and 5 years later, we're being recognized as not a top program, but a top organization. So that's really exciting. So why quality? Well, you're going to see a quote later in the talk, but I'll say it now. I'm involved in quality because, one, it pays my salary. Two, because we now can recognize a maternal and infant health issue and over a 6-month time period, develop an initiative to address it in an 18-month time period, have measurable change in MCH outcomes, our processes. And right now, our current initiatives, 34 of the hospitals are working on hypertension of 120 delivery hospitals in Florida, which is maybe a little bit more than a quarter. However, it represents half of the births of Florida. So that what we're doing on hypertension and pregnancy is potentially affecting 110,000 births a year. So it's exciting to be involved in a process that can lead to that sort of population-based impact. And I will tell you as an epidemiologist, most of the things we do not have that level of reach. So it's been fun and exciting and rewarding. It also has been there because climate has changed. Everybody is supportive in our state. There's nobody who tells us no. They may not want to participate, but they don't say the idea is bad. They don't say what we're doing is bad. They come back and work collaboratively. In fact, our obstetric organization for the state, we now have a district, the past president said, you started out saying we were partners. The last time I went, I'm the only person who presents to their leadership, by the way, at their annual all-day meeting. It's an internal meeting only. I'm the only one from the outside invited. And he said, well, we're just an extension of their district. We're the brains and they're the bronze. Whatever we decide needs to happen, they get it done, which is just a lovely situation. And why I say that is 20 years early, I was in South Carolina. We recognized when our C-section rates were at 28% or 25% that was too high. And we actually started a process of how we could do quality improvement 20 years ago before people were using the QI processes. And I went to one of the lead who would have to help pull it off from the OB side. And his response is, well, Bill, I thought about it, but we really can't tell doctors what they need to do. So we didn't do it. So now the rates in Florida are at 38%, and we're now talking about working on primary cesarean. So here I am in public health, an issue I wanted to work on, and now we finally may be able to really pick those issues up. So let's talk about overview and analytic methods in quality improvement. Now, hopefully you all have clickers. We're going to give you quizzes today. So we're going to see how well you do know. So you do need to try and listen to the methods pieces we get, but I'm going to give you an overview first. Deb Rosenberg and Ashley Harari gave this presentation last year, and I've just tinkered with it. And they borrowed material from Judith Shaw, Lloyd Provost, and Tricia Finnery. And then I'm going to use some examples and test you out on some examples that Manoush Gupta gave me. He is co-chair of NEOQUIC, which is a state collaborative in neonatology in Massachusetts. He just gave a talk at our collaborative meeting this year. So let's just learn a little bit about you. What is your experience with quality improvement? What is QI? I've worked on a couple of projects, a fair amount of information, a good amount of information. I could write the talk, or you could just give me the clicker and I'll do the talk for you. So some of you have now worked on a couple of projects. I can tell you that's a major change in public health and a very positive change, because I would have told you we did this 10 years ago, and the answer would have been very few of you. My experience with data for quality improvement. What's QI? I've never made a run or control chart. I've made a run or control chart. I use run control charts often. I'm a Jedi master. Most of you have never made a run chart or a control chart. Some of you have, and regretfully, I don't have anyone I can give this talk over to. The whole idea of quality improvement goes back to some work that Deming has done, and this is captured by Langley. The idea that you're trying to create change and improvement. What are we trying to accomplish? How will we accomplish it? What changes? And it leads in this sort of what we call an act, plan, study, do. The whole idea is that you're doing this circular process. It talks about rapid change. That's not what we usually do in EPI. Normally we do this long assessment, we do this detailed data EPI analysis, then we describe what the problem is, we figure out what the solution is. This works on a much faster time frame where data is used much more dynamically. The whole idea behind this is data improves quality. The idea is what gets measured, it gets done. This goes back to the point I said earlier. If you've not been measuring it, do not be surprised. In fact, I start out with that with anybody who's never looked at something on their program. I start out saying, okay, this is going to be fun. We should look at this, but don't be surprised. One, the data may be bad because you haven't looked at it. And two, you might not be doing exactly what you think you're doing. But again, it's about planning, then you do, then you study, then you act. Planning does require data to understand the problem and strategies, and it's iterative. It's a constantly iterative process to figuring out, to ensure success, what's effective, what needs refinement, exploring the variation and improvement. The idea is I'm not going to get it right the first time. I'm going to need to do a variety of things. Let's try a few things, see what has happened, try a few more things and see what happens. This goes back to a very important pointing point. There's two types of studies to think about when you evaluate. One is, are we doing the right thing? And that's what we tend to always do. We think about evidence-based program. Does this program work in this population? It's the whole idea of evidence-based practice. However, I would tell you that more things fail because are we doing the right thing, doing it right? And I would tell you that it's not usually choosing the right program. Most programs aren't really doing exactly what they say they're going to do and not doing it in a way it needs to be done. Sometimes it's underfunded. Sometimes it's not well designed. It's not well managed, or there's political context. But this is where we fail out. And again, I would argue 10 years ago, most places in public health were not looking at this latter piece. I'm excited that it's been started to be looked at, and now that the Bureau is embracing it, I think it's helping to change MCH radically, which is really good. The other thing is it's not just PDAs. The idea they start talking about is they talk about driver's diagram. You could call it a planning framework. But what they do is they have aims, they have goals that they want to accomplish, but then they talk about what are the drivers that are going to make these aims take place, and then what are the secondary drivers that drive those drivers. I'm using the example here from Massachusetts, Manoush Gupta shared, where they're trying to improve very low birth weight babies getting human breast milk at discharge, and they think education of the family, breast milk initiation, human milk continuation, and staff buy-in are the drivers. But the idea is by labeling this out, then I can figure out what data I need, and then I can figure out if I'm having the change I need over time to make it happen. Now the key is, as an epidemiologist, you got to be careful. Quality improvement and EPI are not exactly the same. One, QI differs in several ways. One, data is usually collected consistently over time, and they want to do that quickly. And if it's not quickly, it can't really be used for quality improvement. It needs to be displayed continuously. So it's always over time, almost always. It has short intervals that allow quick testing. Small sample sizes, usually smaller than what you want for many of the measures. Does not necessarily include comparison groups. Sometimes it's only historical. If done, they don't use statistical testing per se. They use simple time series statistical tests that are much more rules than really tests. They focus heavy on process as well as outcomes. They want to improve their outcome, but they know they have those drivers. And if I don't change those drivers, guess what? My outcomes aren't going to improve. And if they change all those drivers and the outcomes don't improve, then guess what? They figured out they have the wrong drivers, and we need to go back and get different drivers. But the idea is I'm going to go forward with what I know best, test it out, see if it creates the change I want. The key here is also the focus is on variation in the data and not just rates. And they talk about two types of variation. Special case, meaning something's happening, or two, is it common variation? Is it the variation that normally occurs over time? QI and EPI can be integrated because QI provides impetus for population-based data on a more timely basis. Yes, ma'am.
What is the procedure that you use to vet drivers in these types of procedures?
They usually do what's called a bonefish. And it's a whole process where they start people putting down their best thoughts of what are the contributors to that, and then choosing of those contributors which ones they think can be actual drivers to create change. And then under there they segment it. But if you look for a bonefish diagram, you'll get some idea of what they'll use. The reason I say that is because I already just told you, I want population-based impact even though I'm doing quality improvement. So I do look at my statewide data to see if my quality improvement initiatives are impacting population-based data. And more importantly, the number one reason why vital records is now being pushed out more timely is because of quality improvement. And also Florida's already done it, so it can be done. But I'm just saying the reason we're pushing it out more quickly was quality improvement. In fact, in the COIN initiative where I worked with Ashley Harari, we wanted to look at early elective delivery or non-medically indicated delivery. And in Florida, we started to figure out how to do that as a surrogate measure using birth certificate data. So when we went to the COIN, all of a sudden, we were one of the few groups who could measure their improvements in the COIN because we got every state to agree to give us their birth data about a month after that birth was over with. And we did that for 14 states. And it was fun because we did it and every state participated. And we went to a national meeting and said, well, you can't get states to agree to do that. And it's like, well, that's interesting. We got 14 who did. So you can do it, and it is possible. And so quality improvement is trying to change that timely. And then once we're using it that way, for the first time, there's a reason to make the birth certificate more accurate. Because I'm now using that data for patient care. So the hospitals who provide you that data now want it to be more accurate and want to be more timely because they need that data back to improve their outcomes. In fact, there's state collaboratives now who are focused on initiatives just to improve the quality of the birth certificate. We've been working on this for 30 years, and we now have people doing statewide initiatives to do this that are really changing the quality of the birth certificate. Public health epidemiology approaches provides an impetus to ensure QI initiatives address measurement and reporting issues, because epidemiology is very good at making sure the data says what it says. Sometimes in quality, they don't worry about it as much. The two approaches are synergistic, providing both short and long-term perspective. QI initiatives, we can identify quality issues from population-based data sources. We know our cesarean rate in Florida is too high because our birth certificate tells us that. And we can tell where it's high and who. We just finished an analysis that showed in Miami-Dade, your likelihood controlling for individual medical, social health factors and hospital factors is 78% higher in Miami-Dade if you're low risk than North Florida. It is almost more likely to have it as a risk factor than induction or almost a medical risk factor, just being Miami-Dade. So we can use this to prioritize. We can use it for analysis. Again, population-based data, information priority design for QI. We can monitor change at a population level, and we can give a different perspective than just the clinical people on their own. So the blending of both is very powerful, and it's having good influences on both groups. So what is the role of an epidemiologist? It really pushes us to more quickly think of change over time. We've always worried about change over time, but sometimes we measure it in years, and we only measure it periodically. We're now trying to talk about measuring almost everything in time in a much shorter time frame. And we worry about confounding and others and stratification. We need to make sure we're not choosing something that's biased. We are pushing on comparison groups because yes, quality needs to show that it's making change. But for example, we want to make sure racial disparity is being addressed in those changes. So we are forcing this idea of comparison group, especially with race and ethnicity. We want to clear definitions for numerator and denominators. We do worry about sample size probably more than quality people, and want to make sure we have the right sample sizes if we're going to overly interpret that data. And examining intermediate outcomes, defining of risk factors, and actually improving designs. And so I do actually, as an epidemiologist, play a major role in the data pieces of our QI initiative. Again, roles. As the epidemiologist, we actually define many of the priorities. We justify the need for priorities. We help decide what the best measures are. We develop and test formulas and algorithms that are used for QI for different outcomes. For example, one of the outcomes we're trying to do in quality improvement is severe maternal morbidity. That's actually a CDC outcome that was developed for EPI purposes. We're now moving it to quality improvement. So we actually do develop those formulas and algorithms. We test reporting mechanisms out to make sure they're accurate as well as timely. Assist in providing data, variability of opportunity for improvement. We do assess impact because it's important to say, really, okay, you're doing this on a quality basis. Are you really having the impact you want? For example, early elective delivery now in Florida is down to about 3%. Well, we can estimate probably starting in about 2010, it was probably 25% of all early term births. So we've had a large drop. And now it's below 5% in all but 14% of our hospitals. So it is improving, and we can have that impact at a population level. And QI and population-based analysis is really helpful. That's just a brief overview of QI. It doesn't even begin to cut all surface. Main questions here. Because I want you to make sure you understand this because we're getting ready to go into methods. So we're going to move off the overview. Terminology. Run charts and control charts and trend graphs of the QI world. There are two of the major type of different charts you'll look at. A run chart refers to consistency in points, not a consensus number, but typically at least most run charts about 5 points. In fact, I'll tell you as an epidemiologist, I don't even like to begin to interpret trends without 5 years worth of data. I raise that because, do we look at 3 years, Bill, and do you want to say this is a trend? I pull my hair out with 3 data points because one more data point can have a huge difference. And it looks at contiguous points above or below an average or a median usually, and monotonically increasing or decreasing. And a control chart provides limits and boundaries and works at means and standard deviations and can do some other parameters of measures. So it's much more statistically driven or integrated. The big thing you'll discover in quality, though, is the most important thing about quality is change in behavior. I'll say that again. The most important thing about quality is change in behavior. We don't want to do anything that's so complex that it diverts us from attention to improving quality. If our statistics make it too hard for the people who need to change to understand, then we're not using the right statistics, even though they may be right to us. Does that make sense? It's about generating the data in a way that leads to the change that you want. Now, you may go back and evaluate it more sophisticatedly, but you need to make sure the data you're giving is in a format and a process that can be interpreted. I say that because if you think your program people now don't understand data, Many hospital people don't understand data, at least in Florida. So run charts. It's a graph over time. Usually the center line is a median. There are 4 run chart rules that we'll talk about that are determine random or non-random patterns. A control chart, again, is over time, can be subgroups, usually over time. Center line is almost always a mean. There are upper and lower control limits that are standard errors. Now, the biggest thing I want to tell you is the standard error in a control chart is not the standard error that you learn about in epi and biostatistics. You can't substitute it because it doesn't work the same. Because you're now moving out of what's the normal sort of binomial normal distribution, and you're using a time series approach. So it's a little bit different in a repetitive measure perspective. And just so that you know it, I'm always a show me sort of person. I actually spent time looking at some of our classic data in Florida using the standard error that I'm used to and that they do. And guess what? I got different results. So there are differences. And there are about 5 rules that we'll talk about today that talk about common and special cause variation. But typically a run chart is this sort of simple line with a trend, and a control chart will have much more of these standard line and boundaries and then points around it. I have to have a good cartoon. I like this one. I'm not superstitious either, but those were the 3 days Harris wore his lucky socks. But that's frequently what you'll do. You'll get a run chart back or a control chart back. You'll have an abnormal point, and immediately all these very interesting explanations of why that day or at that point in time it was different. So a run chart. Graphic display of data, simple. In fact, Florida, most of what we use are run charts because our hospitals are not ready for control charts. It's just too much for them. And I'm sure that's true with our program staff at the health department. The data is plotted in some order, usually a time order. Can be an individual, but usually it's a time order. And lets us communicate and understand variation, display key measures over time, make changes for improvement. That's really what's important. You're trying to figure out what do you need to change, and it illustrates if you're making gains on those improvements. So here's a run chart. You have your value on your Y, your time on your X, and you're looking at your data points. And then what you try to look at for variation is the change over time. Not just the point, but the distance between points. That's what we look at with variation. So constructing a chart, you need to select the right measure. That's a very important point. As we talked about X and Y, rule for Y is usually 25% space above and below, so that you have enough space to allow change to take place. You plot the data, you label the graphs, you calculate and add medians, you add annotations for tests for change time. In fact, frequently what you'll see is what we call red circles. Anytime you see a change that fits one of the rules, the standard practice is to put them in red. Why? Because the hospitals won't see them if you haven't circled them in red. Because even though you've given them the rules, that doesn't mean they interpret them. The same is going to be true with your staff. So they circle them in red, and then add direction of the arrows if it's unclear. Again, you tend to avoid the grid lines, regression lines. Your less ink is better because they need to see a simple message. So here are the 4 rules. One is, if you have a median, do you have 6 or more points above the median in a row or below the median? That's one rule for special cause. In other words, something is changing the variation. And if you have 6 points below, that means something is altering that variation. 5 or more forms a trend. That's a non-parametric test for trend. You can actually use that in your epi. If you have 5 consistent points in time that are improving, that's a significant trend. The thing that you don't think about is they want to look up if you have enough runs that are crossing the median. By that, we mean you have a point above and the next point is below are the opposite. And if you have too many runs, that's not statistically correct. And if you have too few runs, that's not statistically correct. And it means something is changing your variation, because theoretically, if it's the same measure over time, it should fluctuate. And then the other one is the astronomical point, or the outliers. We call them an epi. So rule, shift to 6 points more than one direction. Here's an example. You're going along. Maybe here you instituted a new quality measure approach. All of a sudden your points are going down, and you have a statistically significant finding of a shift in your points. It is not, in even 5 points in a row, you could argue that that's a significant trend, but that's a different example. Here's an example of 5 or more points in a row where you're actually having a change in trend. You cannot read this table, but as a good statistician, it's a table that tells you for how many points, what is the upper and lower boundary for how many times you should be crossing the median. Okay? And by crossing the median, if the point's on the median, it doesn't count. You either got to be above the median or below. And depending on how many points you have, they give you the boundaries for that rule. For example, here, how many places do we cross? Really, only one. That is an atypical variation pattern. Rule 4 is an astronomical point. That's something out of line. There's an example of something that's clearly out of line. It's fairly far up above. And again, always this reason why somebody comes up and tells you, well, 3 staff called in sick that day. So, look at this chart. What rule do you think that's going to cause this to vary? I'm going to give you some choices in just a second. So get your clickers ready. Which rule do you think this is going to have issues with? Was there a shift in 6 points? Did you see a trend? Were there too few or too many runs? Is there an astronomical point? Is there just no variation at all? It's okay. I'll let you go back and look at it again. Okay. If I did this, did I now not have you answer the question? Yeah, I closed the poll. I should not have done that. Let me fix that real quick. Let's see if I can fix it. Okay. It's not letting you enter it. All right, well, I won't make that mistake again. We'll just go on. The biggest thing is there's too few runs across. That's sort of at the median and sort of at the median. Those are the only ones crossing, so you have too few. How about this one? Which rule do you think it's going to be on this one? Oh my goodness, it closed all my polls. That's not going to be cool. Oh, it's open again. Try clicking it again. I have no idea why it opened. You all are slow at answering. I only got about half of you. I'll go ahead and close it. Yep, you got it right, guys. You got a shift to 6 right there. So the key is these rules are fairly simple. So they're easy to follow. You don't have to do statistical testing. You don't have to go to SAS. You can just measure them. Again, run charts are probably the minimum for a QI project. So if you're doing a QI project, you should at least be doing run charts because it's not that hard. Put a median up there, know what's going on. Particularly, you want to publish it. You can start with a few points. Remember, it's better with more, though. You need at least 10 points to start following the rules for detection. You don't really have to have software to do it because this one's pretty straightforward. It can be used with all types of data, but it's probably not statistically as powerful as a control chart. Question about run charts? Yes, ma'am.
You said you could use them for something epi, but I couldn't catch quite what that was. There's a few slides back. You said.
Oh, the five points in a row.
Oh, okay.
If you're trying to measure trend, if you have 5 points where there's consistent improvement in epi, that actually will show a statistically significant trend. It's a non-parametric test for statistical trend.
Can the rules overlap?
Yes, you can have more than one rule in one. Now, why do you want to know special cause variation? If you're intervening, you want to know that the variation changed. Because if I intervene and I have no special cause variation, then what's my initiative done? Nothing. So the whole idea of these tests are, I'm doing something over time, I'm intervening here. Is there a change? Is that change happening or not happening? Now, you already know if you're going to say it's going to happen at least 6 times before you know for sure it's a change. So you don't want to wait years and 6 years to say, it finally changed after 6 years, congratulations. They won't even remember the change 6 years back. It's probably not even the same staff. So you do need to try to have intervals that allow you to do that repeated nature. Control charts are skew charts. Again, they want to try and talk about common variation versus special cause. Now, the run charts are good at special causes. The variation is just not the same. Why do we worry about common variation? What do I mean by common variation? Normally with a binomial, I can approximate the binomial because I know what the rules are for variation of a binomial. And believe it or not, clinical practice doesn't follow binomials. So the key gets to be if you're doing something in clinical practice and one group has a very small type of variation, and the other group has a very large variation, what is that telling you? Someone has processes in mind that do a better job of making sure that you're having the right process or the right outcome. The wider that variation is, it means the less tight or looser what you're doing is, and that everything's happening all over the map. So that over time, if this is the right thing, I'd like to have not only an improvement in rate, I also would like to know I'm not varying every day depending on who's on shift or who the home visiting person is. Or does that make sense? So the idea that you want to reduce variation is not just special cause, but you want overall to have the right outcome or the right process almost every time. We'll talk about variation. Again, the statistics are all based off of a mean and a different type of standard error for this type of control chart from the mean, and you need at least 20 points. Most likely, control charts are going to be used retrospectively as an evaluation of what you've done. And usually they're not used prospectively in the middle of the project. Why? Because they're harder to do. You got to wait till you have at least 20 points before you can get there. But usually that's done. But they can be done during, because if you have a long baseline, you can get up to those 20 points fairly quickly. And the idea is you're not trying to look at change all the way across. What you're really hoping for, guys, is change in the future. the whole idea here, this is a change process. So you're trying to use statistics to help you see if the change is going to happen, because that's what you want to have happen. There are 5 different types of control charts. So I expect everyone to remember this. No, I'm teasing. But you have discrete or continuous data. You have a count data versus a classification. Equal or unequal opportunity for improvement. Lead to 2 different charts. Equal or unequal, here you're talking about basically a percentage, and it's percent classified a certain way. And then on a continuous side, you've got either equal subgroups or varying subgroups and such. Why do they have this? Because the statistics for each control chart is going to be different based off of the type of data measure you're trying to look at. Now, I'm not going to go through all 5 of these because you all would fry me for lunch. But I am going to walk through the 2 more common ones. But I do want you to get some idea here. Okay, rules for detection with all 5 P charts. If you are more than 3 standard errors out from the mean, that is considered outside the control limits. Okay? Interestingly enough, with control charts, it's not 6 points above or outside the mean. It's now 8. So there's a rule change. Notice that. Run charts, it's 6. Control charts, it's 8. In a control chart, it is 6 consecutive points going up and not 5. The other thing that you can have, though, is now that you have 3 standard errors or 2 standard errors or 1 standard errors, if you have 2 points that are outside the 2 standard errors together near each other, that's the same as having 3 levels out, and it's another outlier. And if you have a point that crosses the middle, you ignore that point. The last one is if you have 15 consecutive points that are near the center line, compared to the normal line, all of a sudden you have 15 points, it means you have also probably a variation issue. And that would be a common variation. These would all be special causes, and this would be common. Okay. Going back to the previous chart that I showed you for first feeding of human milk, percent of all infants who are breastfed human milk, this is your trend. With this type of measure, this is a percent measure of all infants, which run chart would you do? I'll give you time to think about it. Okay, is this continuous data or is this discrete data? You're either getting human milk or you're not. So it's going to be one of these 3. Okay, hopefully you got your clickers ready. Which type of chart do you want? This is painful, I'm sorry. Let's see what you all said. Most of you said it's a P chart, and that's correct. I don't know why this slide is not showing up, but it's discrete, it's a classification, there are equal or unequal side charts, and it's a P. So you got that correct, I'm impressed. Let's go to a different chart. Oh, here's the run chart, I'm sorry. So looking at this run chart, control chart, we'll back up. This is a control chart. The reason you can tell is there's the mean, here are the standard errors, 1 standard error out, 2 standard errors out, 3 standard errors out. Here's where the improvement took place. in this initiative. So, how would you interpret this chart? Poll is open. I got one respondent so far. Okay, I'll go ahead and close it. 6 trend points or no special cause variation. Let's take a look. There are actually not 6 points in a row anywhere. And what used to be true with our run chart is no longer true with our control chart. 2 things. The mean is now above this other point, but 2, there's only 1, 2, 3, 4, 5 points that are above the mean, and it takes 8. Remember, in a control chart, it takes 8, not just 6. So this one actually showed no special cause variation. Now for this next driver question and measure, it's going to be a little bit different. We're now going to look at the measure called time to first use of human milk for oral care. The first breast milk that a mom has come out has been now documented to greatly benefit the future mouth care of the baby. It has the ability to actually prevent cavities and a variety of other issues. So mom's initial breast milk, even in premature babies, is essential that they get it. And so the question is, how long does it take them to get their first for mouth care? It also actually changes their biome within their gut. And we think that may be good. Again, just because it changes, we don't know what that means in the long run. Here are the measures. You've got different measures in a month with different times. So what type of control chart is this one? I'll give you a clue. It starts out being continuous. You now have your choice. Well, the good news is the other top 3 were on the discrete side, so I'm glad you all picked that one up. But it is continuous. It has subgroup size greater than 1, so therefore it's an X bar and an S chart. Now let's talk about this, because all of a sudden now we're going to go from 1 control chart to 2. You're going to have a control chart for the actual mean value that month, and then you're going to actually have one for the standard error. One is going to tell you what's happening to the actual measure. One's going to help tell you what's happening to the common variation. They may tell you very different things. Because the key here in a quality measure is you want to be reducing the average time and you want to be reducing the variation. So you want to be doing both in the quality because you want to have a tight process that leads to a better outcome. And normally in public health measures, we only worry about number 1. But from a quality perspective, you want every baby or every mom or every family to have that same opportunity. That's a quality issue. So it looks at two types of process changes, the mean and the standard deviation error. Either change can be without the other. They're not tied to each other. We've discovered in QI. And one chart to detect each of the different types. So here's an example where the mean is changing and the variation didn't. And here's an example where the mean is not changing, but the variation did. So the idea is they're not necessarily tied to the same, and what you need to do to change them may not actually be the same. So if you look at this, I'm going to be asking you a question. Looking at both, this is just the top graph on X bar. Is there any variation rules here that are different? Of the 6 rules that I gave you, are any of these different? Poll is now open. There's no special cause variation. One or more points are outside the control limit. There's a shift below the median. There's a trend in decreasing points, or more than one. I'll close the polling. It's B and C. Okay, it is both. Now you can see the benefit of the red line. Here you can see there's 1, 2, 3, 4, 5, 6, 7, 8, 9 points below the mean, and then there is this one up here. This shows you why red circles are helpful, though, because people will miss these, and so it's a good thing to do. This was on the variation piece. I screwed it up. We'll just go forward. The rule on the variation piece is you are approaching, you have 1, 2, 3, 4, 5, over 6 points here that are below the mean. Takes 8. So you don't quite make it. But again, that's what you're trying to do. It takes 8 points below the mean. Control charts. Control charts in some ways are more sensitive. Some ways are not. Remember, it takes more points above and below the line. It takes more points for a trend. So in some ways, it's less sensitive. But in some ways, it's more sensitive because it's testing for more change than a regular run chart would. Okay, you're looking at things that you wouldn't any other way. More importantly, you have boundaries. So some rules go to 3 standard errors out versus 2 out. So you do have a little bit more sensitivity and power. It minimizes the likelihood of a false discovery because it has more precision and push more on the p-values. It estimates the capability of a stable process and not just special cause, but it's much more difficult to generate. Now, the other one thing I want to do is talk about most of the quality improvement we'll look at as a change over time. But you can also use these measures to look over time within a unit, and all the units over time. Most look over here, I'm sorry. Most look over time. But you can look at it between. From a public health perspective, this actually might be a very useful approach. Let me give you an example. The above one is a control chart for the 2012 infant mortality rates. And that top one's hard to interpret. But if I sort them by their degree of variation or their own standard errors, what do you notice? You can start clustering states that seem to have higher funnels in one area and lower in others. So it'll help you choose, because one of the things when you do in quality improvement usually is to get those users on how to improve, you look at those who have really good rates versus those who have really poor rates and say, so what's going on differently? It's a common quality improvement approach. This sort of, and they call this a funnel chart because it forms a funnel. But this sort of funnel chart is a good way when you're looking at across hospitals, across county health departments, or counties. You can start saying, who are your outliers? What's different in those places than others? You can even break this down by race. So you can look at it here, and you get a different one for, this is for whites. This one here is for blacks. This one here is for Hispanics. This one's for American Indian. But you can see that even when you control for race, there are still some states that have really good black infant mortality rates that really stand out beyond the boundary of what you would expect. So what might they be doing, or what's going on with blacks in those states versus some other states up here who are really on the higher end? I'll give you some example. You got Alabama up here. You have Illinois. Down here you have Massachusetts, New Jersey, California, New York. So it gives you some places that you might want to explore between states or between counties. What's different about your population and why? Now, I did want to bring up a point just for the future. They're going to talk about Joint Point. We do some time series stuff with you all, and Joint Point is a nice tool. It's not something usually used in quality improvement, because part of it gets to be in public health. Sometimes we're looking for what is this change point. But what they're more interested in looking at is variation. You were here, you're now here, you're now here. Because again, we want to know not only did it go down over time, we want to know, are you keeping it down? Is it stable down? Is there a real shift in the mean and the limits? And the good news is, just like Joint Point, there's actually software that you can use for control charts. What I go over today, you don't have to generate your own. And regretfully, it's not in SAS, STATA, or SPS. You've got to use something very different, and I'm very frustrated by that. Because we're trying to generate it for a hospital, and it's very hard.
SAS has a QC package, but it is optional.
Can it do these well?
Can it do U-charts? I think so. Yeah, I haven't done one in years. But.
Okay. Well, we may have to look at their QC package then. We may have been missing that opportunity.
Okay.
Well, so we'll explore that.
Okay, yeah. I mean,
The standard package doesn't have it, so it may take a special package.
Yeah, I believe there is a special package.
And of course, SAS is always so inexpensive, it shouldn't be an issue.
Oh, yes.
When do you revise your limits? Because you noticed here, the limits changed. There are some rules. Trials that are calculated sort of can't be really done very well with fewer than 20 subgroups. It's very hard. So you can need at least, I'll say it again. You have to get it at least to 20 subgroups before you start trying to do it. When the initial control chart has special cause, that might be a time to consider changing it. When improvement process resulted in special cause. And when the control chart is unstable for 20 or more subgroups. When all of a sudden you see a lot of variation, it may be worth looking at. Why didn't you say you were a Jedi Master, Michael, after our discussion last night?
What's that for I haven't done a lot of charting. I've generated a lot of data for people who have done.
Michael used to work for VAUGN, which is Vermont Oxford Network. For those who don't know, that organization provides quality data to 90% of the NICUs in the United States. And so they do a lot of hospital reporting, and we're now using it at a state level to get state reports to try and look at issues. Here are SUID rates. These are SUID rates in 4 different states. You can see in California they actually had a real change. It did not get picked up in New York, although the pattern is somewhat similar. It did not show significant change. And here is Arkansas and Mississippi, and they've not reached them yet. However, that's 7 points, not 8. So they're getting close. I would actually call that 1, 2, 3, 4, 5, 6 points up. That might be reached special cause, but it's not changing the control chart. I'm not here commercial advertisement. I have no conflict of interest. If I owns no stock in this company, there is called a QI macro. And this actually has a spreadsheet that can be plugged in to your regular Excel spreadsheet. And it can actually generate all these different charts for all your different data. It's very easy to use. You highlight the columns for the different data that you need. It automatically generates the charts. It knows all of the rules, so it puts all the changes that pop up in red so that you know what they are. And so if it's supposed to do both a mean and a standard error chart, it knows to do those automatically. The problem is you got to go to a spreadsheet for each and every unit to do it. Now, if you're doing a home visiting program, that might still be doable. I like it because it's very complex to do these different charts. And so we do use it in the few initiatives that really have to have a control chart and not a run chart. About $200. A little bit less than I bet you SAS is, but I haven't checked out the price. R does? It is free. R's nice. How many people in here use R? That's far more than what used to use R. It's becoming more popular. What? I am finding that people are learning on it some because universities are finding it free, and so they don't have to pay for it. And students can have access to it. Examples from the field. Questions on methods before we talk about examples? Here's an example in WIC. WIC is definitely a place where quality improvement methods can be used and could actually be beneficial. Here is the no-show rate for a county there in WIC. And you can see 1, 2, 3, 4, 5, 6, 7, 8 points below a line. So obviously, if they did something, they're showing a special cause variation. So a WIC clinic or any of your clinics could clearly benefit from quality improvement measures if you're not doing those. Here's an example from Illinois. I mentioned how they're using quality improvement methods to include reporting on the birth certificate. This is providing the accuracy of different variables on the birth certificate that Illinois is now trying to get into a range where the quality is sufficient. California's also done some quality improvement on vital records, and so is New York. Here's in Florida. We did a quality improvement with the big five states. This only includes the Florida results, not the 5 big states, but they had the same findings. But essentially, we went from early elective delivery in 6 hospitals. In January, we were about 38%. In 12 months, we were down to 5%. This is what's happened with cesareans and inductions. In our analysis that we published on cesareans with early elective delivery, at one point in Florida, 46% of our low-risk women, that didn't have an indication to be delivered early, were being voluntarily delivered early for repeat cesarean. Almost half. And we know that every week matters for how long a baby waits to be born if there are no risks. Here's Ohio's early elective delivery. This shows what's happening with private insurance and showing with Medicaid. It's interesting how private insurance tended to have a higher likelihood of delivering earlier than Medicaid did. Here's the birth certificate quality improvement measure over time, what they looked at as non-elective delivery, and they talked about how your hospital's doing versus the network versus Illinois overall. So again, you can do different comparison groups, and we frequently do different comparison groups. One of the things we do to try and put pressure on hospitals is, usually with our initiative, we show how you're doing and how you're doing compared to other hospitals in the initiative so you know if you're ahead or behind. Again, your context is different, but if you want to find out, do I need to be learning from others what they're doing and how they're doing it, being behind is a way to learn. Here's Ohio in their reporting of antenatal steroid use. This is interesting because this is what it was on the birth certificate before they decided to post it on the internet for all hospitals. And all of a sudden, the quality improved up to here. And then they started their antenatal initiative to try and improve the use of antenatal initiatives, and their records improved here. They got up to about 90%. It's still not completely accurate on the birth certificate. It should have been about 95%. But still, 90% and 95 is a whole lot closer than most of us, because most states, if you're not doing anything here, are at about 40% when it's probably much higher. And your quality things do not have to be just that simple. Here's Florida and the nation on reducing infection due to catheters. Babies who are born prematurely frequently need to get catheters in their umbilical vein, or they get something in their central line to get fluids and antibiotics and nutrition. The problem is it also becomes a focus for infection if it's not managed well or it's kept in too long. And essentially in this quality improvement initiative over an 18-month time period, they avoided, in Florida, 150 infections. We prevented probably 18 deaths based off extrapolation from external data. We reduced the stay in the hospital probably 1,200 days and about $8 million. So when we talk about these quality improvement initiatives from a perinatal perspective, we have a huge impact, not just in quality, but overall cost. For our early elective delivery initiative in Florida for a 24-month, about 30-month period for early elective delivery, one of our insurance companies estimated that we saved them $4 million. That's one insurance company. We saved them over about $4.2 million. Non-medically indicated deliveries here in the COIN. For those who didn't know, the COIN projects and infant mortality started in the southeast and southwest, 14 states. When we worked on non-medically indicated deliveries, when it was much higher, we used birth certificate data, but here's what happened in Region 6. Here's what happened in Region 4. Region 4 was not nearly as high up as Region 6 was, but we started to go down. Region 6 may have started to plateau a little sooner. You can look at the percentage decreases, though, and see how we're doing. So this allowed us to work across states to learn from each other, and having state data was very informative to do that. And here is all of the states. What I'm trying to do here, though, is I want to point out two states. This is one state that deserves extreme applause. We started in about 2012, and this is Mississippi. And here's where everybody else was. And this was a realization time period that they weren't going the right direction. Their state health officer immediately has started to work with the March of Dimes and others. At the end of the COIN initiative, even more amazingly, now with the new CMS data, Mississippi is better than a large numbers of states. So they probably had one of the highest rates in the country and now have had substantial reduction. So it was very powerful when we're sitting there on a call with 14 states and the health officer in Mississippi is going, and that's us? That's not okay. Interestingly enough, here is New Mexico. They always were good. They didn't think they needed to be monitoring this because it didn't matter. And then all of a sudden they went like this, and they discovered one of their largest hospitals started to have an encroaching process of trying to deliver babies too early because of some changes in practices. And with this data, they realized an opportunity for intervention was available. So it's helpful to have this type of data. Lessons learned from the COIN. I hope this is a message you walk away with in quality improvement. What gets measured gets done. Now, not everything that counts is counted. Think about that one. Not everything that counts is counted. But if you're not counting it, it's likely not necessarily being done. But you can't fatten a calf just by weighing it. In other words, the data alone is not sufficient. I don't know who came up with that one. Was that? It's an Israeli proverb. Okay. I was worrying about you, Ashley. Data is for improvement, not for judgment. When we talked to Mississippi, this was not to make Mississippi stand out. It was the discussion with Mississippi of where are you? Are there ways to help? How can we intervene? In QI, the other thing we like to say is we want to improve our failure rates. In QI, you learn by doing something. If you're not doing anything, guess what? You got the same problem sticking around. The whole idea in QI is do something, test it out. If it didn't work, that's okay. You now know that doesn't work. Move to what does. In other words, you learn by making mistakes. And that's normal. The idea is to work smarter and not harder. The idea in quality improvement is we try to reduce the data burden. We try to keep the statistics simple. We try to make it so that you can make quick and easy, rapid decisions and not weigh you down with a huge amount of bureaucracy. I would tell you that epidemiologists, it's hard sometimes to look at the data they collected. Well, they could have collected this. This really would have been helpful. I wish this had more detail. What do you mean you're only including 20 women? That's not a very good sample size. All those things are important. Share seamlessly and steal shamelessly. One of the nice things about collaborative, every collaborative in the country that I know of the state collaboratives, puts all their information out on the web. You can ask any state for what they've done, how it worked, and where it is. We borrow and change. I used Manusha's slides up here. He was very glad to share those examples from Massachusetts. So it's a really nice thing to have in QI. Most of us want to learn. And the good news is places that are doing good really don't mind telling you what they've been doing because they're proud of it. So it's a great opportunity to learn. Learn, spread to scale, and improve everybody. I've already talked about mine. Deb's personal discovery, she would say, is integrating QI thinking and methods to epidemiology thinking and methods strengthens both. And I really can't emphasize how true that is because we've always wanted our data quicker. But now with QI issues, we can give a strong rationale of why we had to have it done. I mean, we had a few states who didn't want to provide their early elective delivery data from vital records initially. And one of the state health officers picked up the phone and called the other state health officer. This is what it is. This is how it's going to be used. And you know what? Everybody could give us the data. It takes work, and sometimes you need to make sure the resources are there, but everybody could do it. So the idea of timeliness and accuracy, it really helps us all very much. The data are applied in different ways. It's not like one replaces the other. And a wider range of people get energized and involved, and it will create new partners. Even in your home visiting, as you work on quality improvement, you'll start including more of your community providers because as you look at the quality measures in home visiting, it's not all done just by the home visiting program. So when you start looking at quality, there's others that adds new people. Final wrap up. They are different. Quality improvement, performance measurement that we use in the block grant, and research and evaluation are different. They have different aims. One's to improve the process and system. One is to promote accountability. One is to generate new knowledge. The audiences are different. Program managers, funders, society. The scales are different. The timeliness can be different. The biases that you have could be different. Some have comparison groups, some do not. Some maybe have to do randomized and experimental. The sample size and improvement is you want just enough. You don't need everything. It doesn't have to be statistically precise. Where in performance measure, you want 100%, and in research, you want to have just enough data to make sure you can make your point. Flexibility. Quality improvement is very flexible. Research is not flexible at all. And in performance measurement, there's no hypothesis. And determining if change is an improvement, run charts and control charts do that by just design, which is very different than hypothesis testing and what you might do. So they're powerful, they can help each other, but they're not the same. Questions? Yes, ma'am.
Expand on the one point that you made that in QI we want to increase our failure rate.
Well, I can go back to that. That's very easy. Let me ask it a very different way. If you have appendicitis, do you want to go to and you know that you need surgery if you have acute appendicitis. However, that's now changing. That may not be true. But if you did, do you want to go to a surgeon who is always right every time he decides to do surgery? Or would you like to go to one who occasionally pulls out a normal appendix? I'm using it as a concrete example. You actually want the latter, because if they're right every time, it likely means they're missing some appendicitis that should have been removed. In other words, no one is right in both directions. So if the whole idea is about change for improvement, you want your failure rate to increase because you're doing changes. If you're doing no changes, guess what your failure rate is? It's 0. Our whole idea is we want people to think about it from a learning perspective, a quality perspective. And so we want to create not to have change for change's sake, but we want to have processes that are changing to try and improve themselves. That means they're going to be wrong occasionally, Anna. So your failure rate's going to go up, but your ability to improve quality is also going to go up. Does that make? Because in the quality improvement, not everything you do is going to change. There are a lot of really good ideas that don't change things. One of the interesting studies that Hospital Corporation of America, I'm not a big proponent of commercial products, but they did a very nice quality improvement study. They had one group of nurses and doctors that they didn't do anything with early elective delivery. They had a middle group, they did intensive education of both nurses and doctors. And then another group, they actually put a hard stop policy in place that you had to have certain conditions to deliver or get special permission. Otherwise, you couldn't do an early elective delivery. What do you think the results were? Well, the group that only did education of the doctor and nurses, how many people think that caused a lot of change? It caused a small amount of change and it didn't sustain itself. It wasn't until the environment changed that forced people to change behaviors. Because remember, from your public health training, education doesn't change behaviors. Education helps with behavior change, but it's only one of those steps in changes. But the policy actually was what's been the driving factor to reduce early elective delivery in almost every hospital in the United States. We only know this by testing out what works and what didn't work. I just try to use that as an example of even good ideas don't always work. Other questions? Well, I think I am going to give in a little early, Kristen, and give you all more time.